Okay, good afternoon, everyone. Welcome to 99th Continuing Medical Education, organizing by Faculty of Medicine, Bioscience and Nursing, MAHSA University. Today we have two speakers for this 99th event of the CME. One is first speaker is Associate Professor Dr. Nilar Khin, and she'll be talking on non-neoplastic nasal polyp, single or multiple. And another speaker is Associate Professor Dr. Uday Dadhwal, Department of Surgery. He'll be talking on guidelines for the detection and management of the bile duct injury during the cholecystectomy. And let me introduce to the first speaker of the day, that is Associate Professor Nilar Khin. And she's working as Associate Professor at Department of ENT, Faculty of Medicine, Bioscience and Nursing, MAHSA University. And she did her MBBS and Masters in ENT at University of Medicine 1, Yangon, Myanmar. After that, a couple of years, she working as a otorhinolaryngologist, ENT hospital, Yangon, Myanmar. And after that, she worked as a senior lecturer, assistant professor, and head of department at UCSI. And she joined us in June 2021 as associate professor and faculty of medicine, bioscience, and nursing at MAHSA University. And at present, she's also serving as Year 4 ENT posting coordinator and Year 4 MBBS coordinator. With her interest, she also had some certificate courses like Certificate in Essential Skills in Medical Education, Association of Medical Education in Europe, and also is a certificate in Good Clinical Practice from Clinical Research Center, Ministry of Health, and Malaysia. So today, without many further ado, I would like to invite Associate Professor Nilar Khin to talk on non-neoplastic nasal polyp, single or multiple. The floor is yours, Prof.
Thank you very much, Prof. Suresh, for your kind introduction. Good afternoon. I am Dr. Nilar from ENT Department, MAHSA University. Today, I would like to talk about common ENT problem with the title Non-Neoplastic Nasal Polyp, Single or Multiple. This is the outline of my presentation. As we all know, a polyp is an abnormal growth of tissue that protrudes from the lining mucosa of alimentary tract, respiratory tract, and reproductive tract. They may be either benign or malignant cancer. Some examples are colonic polyp, rectal polyp, and cervical polyp. In our ENT practice, we have oral polyp, nasal polyp, and vocal polyp from ear, nose, and throat. Today, I will talk about nasal polyp. This is the experience of patients with nasal polyp. They suffered from progressive bilateral nasal obstruction and nasal discharge for many years and often associated with reduced sense of smell. These symptoms usually disturb their social life. That's why they need to bring along all the medications and tissue papers everywhere and feel embarrassed of their problems and symptoms, and that's why they seldom participate in outdoor activities and prefer to stay at home. That's why nasal polyps have a huge impact on the patient's quality of life, and it affects a patient's emotional well-being. Directly or indirectly, there is a significant financial burden on society, directly as a result of outpatient appointment, prescriptions, investigations, and hospitalization, and indirectly as a result of missed work and decreased productivity at work, because nasal polyps are common in working age group. Since the nasal polyps arise from the nose and paranasal sinuses, I would like to discuss a brief anatomy of nose and paranasal sinuses. External nose is made up of osteocartilaginous framework, and there are two nasal cavities divided by nasal septum. And nose is not alone, it has neighbors. We call it paranasal sinuses. We have four paranasal sinuses: maxillary sinus in the maxilla, frontal sinus in the frontal bone, ethmoid sinus in the ethmoid bone between the orbits, and sphenoid sinus in the sphenoid bone at the skull base. These paranasal sinuses open into the nasal cavity. Nasal cavity is lined by ciliated columnar epithelium, and this mucosa is continuous with the paranasal sinus mucosa via the openings. And olfactory mucosa is at the roof of the nasal cavity. This is the lateral wall of the nasal cavity, and it has three bony projections called turbinates. We have superior turbinate, middle turbinate, and inferior turbinate. The area below the turbinate is called meatus. These paranasal sinuses open in this meatus. Maxillary sinus, ethmoid sinus, and frontal sinus open in this middle meatus, and sphenoid sinus opens near the superior meatus. This is the picture of lateral wall of the nasal cavity, and this is the anterior opening, and this is the posterior opening. Posterior opening of the nasal cavity is called choana. Behind the nasal cavity, it is nasopharynx, and here you can see the opening of the eustachian tube, because eustachian tube connects the nasopharynx and the middle ear. In this picture, you can see the opening of the paranasal sinuses in the lateral wall of the nasal cavity. The functions of nose and paranasal sinuses are very important because it is airway for our respiration, and another important function is olfaction. That's why in patients with nasal polyps, they have nasal obstruction and disorders in smell, like hypospia or anosmia. So what is nasal polyps? It is a painless swelling formed inside the nasal cavity or paranasal sinuses. They vary in size from a few millimeters to several centimeters. Annual incidence is 1 to 20 per 1,000 population, but it declines after 60 years of age. And prevalence in normal population is 1 to 4% in adults and 0.1% in children. But the incidence is much higher in certain systemic diseases, and it is more common in male, but no racial predilection. The etiology is very complex, and exact cause remains unknown, but infection and allergen plays a prominent role in the pathophysiology of nasal polyps. Infection of the paranasal sinuses is called rhinosinusitis, and Staphylococcus aureus and Pseudomonas aeruginosa are common responsible organisms, and allergens like inhaled allergens, pollen, dust mites, molds, animal denters, and citrus moths responsible for formation of nasal polyp. Some systemic diseases are associated with nasal polyps. For example, asthma. Some percentage of asthma patients have nasal polyps. If they have aspirin intolerance or aspirin hypersensitivity, the occurrence of nasal polyps is increased and more severe. And other systemic diseases are allergic fungal sinusitis, cystic fibrosis, especially in the children, and Cartagena syndrome or Young syndromes. So etiology is chronic inflammation. That's why nasal polyp is the end-stage local manifestation of chronic inflammation in sinonasal tract. It is non-neoplastic masses. It is not a benign tumor. It is not a malignant tumor, but it is a benign condition. And it is a subgroup of chronic rhinosinusitis. In chronic rhinosinusitis, we have chronic rhinosinusitis with nasal polyps or chronic rhinosinusitis without nasal polyps. In pathogenesis, chronic inflammation of nasal lining mucosa causes collection of extracellular fluid lead to edematous mucosa. That edematous mucosa causing the polypoidal changes, and we can see as a polyp. Like in the picture, it is pale and smooth and very different from the surrounding vascular mucosa of the nasal cavity. When this edema herniates through the basement membrane, polyps forms. In histology, it consists of loose connective tissue, inflammatory cells, and fluid, usually covered by pseudostratified ciliated columnar epithelium. But later, it changed to transitional or squamous epithelium. Macroscopically, it is sessile in the beginning, but becomes pedunculated due to gravity and excessive sneezing. Complications include recurrent or chronic sinus infection, obstructive sleep apnea, or malignant change. There are two types of nasal polyps, ethmoidal polyps and enterochoanal polyp. Ethmoidal polyps arise from the ethmoid sinuses. If you look at the CT picture, in ethmoidal sinus between the orbits, you will see many air cells. But in enterochoanal polyp, it arises from the maxillary antrum, and in the maxillary antrum, there are only one air cell, or we call it antrum. That's why if polyp arises from the ethmoid sinuses, usually multiple, because polyps arise from each and every air cells, but in contrast, in enterochoanal polyp, usually single and unilateral. So in ethmoidal polyps, usually multiple and bilateral because of anatomy and nature of ethmoid sinuses, but in enterochoanal polyp, usually single and unilateral. They occur at any age, but ethmoidal polyps mostly seen in adults, usually between 30 to 60 years of age, and that is working age, but enterochoanal polyp is common in children and young adults, and both are common in men. They vary in size, but ethmoidal polyps is usually seen in the nasal cavities, but enterochoanal polyp is usually seen in posterior part of the nasal cavity, because these polyp tends to grow backwards towards the posterior opening choana and nasopharynx. That's why it's named enterochoanal polyp. Arises from the maxillary antrum and grows backwards towards the choana, enterochoanal polyp. But if it is large, it may hang down behind the soft palate and presents in the oropharynx. Clinical presentations. They present with various symptoms, depends on the extent of the disease. In ethmoid polyps, if small polyps may be asymptomatic or just mild nasal congestion with a watery rhinorrhea, in large polyps, there may be significant symptoms like persistent nasal obstruction or hypoxemia or anosmia. In an enterochoanal polyp, it presents with unilateral nasal obstruction because it is usually single and unilateral, but ethmoidal polyps, bilateral obstruction, nasal obstruction. What are the other symptoms of nasal polyps? Because of the underlying rhinosinusitis and allergy, they have yellowish nasal discharge, headaches, facial pain, sneezing, or watering nasal discharge. Because of the mask effect, they may have difficulty in breathing through the nose, noisy breathing, snoring, or if large enough, you can see the mask protruding from the nostrils like in the picture. In long-standing cases, there is broadening of the nose as shown in the picture. So in examination, we have anterior rhinoscopy and posterior rhinoscopy. Anterior rhinoscopy is examination of the nasal cavity through the anterior opening, and posterior rhinoscopy is examination of the posterior opening and nasopharynx. In posterior rhinoscopy, we use the mirror. And we have nasal endoscopy. In nasal endoscopy, we use rigid or flexible scope, and we can detect mucosa edema, mucopurulent discharge, nasal polyps, septal deviation, enlarged turbinates, and sometimes we can do nasal swab for culture and sensitivity. So what are the characteristic features of nasal polyps? It's usually smooth, glistening, rounded masses seen in the nasal cavity, often pale in color, and it may be sessile or pedunculated and insensitive to probing and do not bleed on touch. It is insensitive to probing because it is just a mucosa edema. In contrast, nasal mucosa is sensitive to probing. In enterochoanal polyp, it may be missed in anterior rhinoscopy because it grows posteriorly. Sometimes you may see just a stalk. So this is the anterior rhinoscopy picture with the nasal speculum. So this is the characteristic features of nasal polyp. Because ethmoid polyps is usually multiple, you can see as the gray-black masses when you perform nasal endoscopy. But in enterochoanal polyp, you will see a globular mass posteriorly in the nasal cavity, filling the choana or the nasopharynx. So this is the endoscopy pictures of ethmoidal polyps, you will see grape-like multiple masses in the nasal cavity, and in this picture, you will see the single swelling in the posterior part of your nasal cavity. If enterochoenal polyp is enlarged, it grows into the nasopharynx, and sometimes it may hang down behind the soft palate, and you can see through in the oropharynx. So this is the summary of differences between ethmoid polyps and enterochoenal polyp. Ethmoid polyps arises from ethmoidal sinuses, and it is common in adults, and it is usually multiple and bilateral, but enterochoenal polyp arises from maxillary sinus and common in children and young adults, and usually single and unilateral. Ethmoid polyps grows anteriorly, but enterochoenal polyp grows posteriorly towards the choana. Recurrence is very common in ethmoid polyps after surgery, but in enterochoenal polyp, it is less common. The diagnosis is just by history taking, physical examination, and endoscopy examination. So it is a clinical diagnosis, and we usually diagnose as chronic rhinosinusitis with nasal polyps. So you will notice nasal polyps usually do not present with epistaxis. This is the diagnostic criteria for chronic rhinosinusitis with nasal polyps. Clinically, endoscopic examination and CT changes. So clinically, 2 or more symptoms, one of which should be nasal obstruction or nasal discharge, plus or minus facial pain or reduction or loss of smell, and either endoscopic evidence of polyps or mucopurulent discharge and mucosal changes in CT scan. So that's why facial pain or headache alone is not a diagnosis for chronic rhinosinusitis. So because nasal polyps present with nasal obstruction, the first differential diagnosis is deviated nasal septum, as shown in the picture. But in deviated nasal septum, usually there is no nasal discharge unless patient has underlying allergic rhinitis. Second differential diagnosis is turbinate hypertrophy. The causes of turbinate hypertrophies are allergic rhinitis, non-allergic rhinitis, vasomotor rhinitis, or rhinitis medicamentosa. In turbinate hypertrophy, you will see the turbinate in the pink color or red in color, and it is sensitive to your probing. And third differential diagnosis is inverted papilloma. It is the most common benign tumor of sinonasal tract. Sometimes we have to think about malignancy, especially in old age men with chronic smoker with unilateral nasal symptoms with epistaxis. So malignant sinonasal tumor or nasopharyngeal carcinoma. The last differential diagnosis is juvenile nasopharyngeal angiofibroma. It is the vascular tumor, and it is the most common nasopharyngeal tumor, benign tumor, but it is locally aggressive. It commences in adolescent male, and it presents with unilateral nasal obstruction in some cases, but usually it presents with epistaxis. So important points you have to be thinking about are age and sex, unilateral or bilateral nasal symptoms or other associated nasal symptoms, and neck lumps. For malignancy, they will have metastatic lymph nodes enlargement. In children, a simple polyp may be glioma or meningocele or meningoencephalocele. Callus removal results in CSF rhinorrhea and meningitis. Multiple nasal polyps may be associated with cystic fibrosis. In adults, when you suspect malignancy, so you suspect malignancy in old age men with unilateral nasal symptoms, especially presenting with blood-stained nasal discharge or epistaxis. So in investigation, sinus X-ray is little or no value. So that's why CT scan of nose and paranasal sinuses is a radiological investigation of choice. You can detect the extent of the disease, degree of sinus opacity, any anatomical variation, or we can exclude bony erosion in malignancy. Actually, it is a roadmap for surgery. because neighboring structures are very delicate structures like eyes, orbits, and brain. So this coronal view of the CT scan shows the opacities in most of the paranasal sinuses and nasal cavity, but in this picture, you'll see the opacity in maxillary sinus. So this is the antrochoidal polyp. So biopsy is usually done even in the simple nasal polyp, especially in patients above 40 years of age, because it may be associated with malignancy. We have staging systems to determine the extent of the disease, to facilitate medical communication, and to evaluate therapeutic responses, especially in the research cases. We have endoscopic staging systems and radiological staging systems. I will not go through in detail. So in treatment, the aims of the treatments are to eliminate the symptoms and nasal polyps, to re-establish nasal breathing and olfaction, to prevent recurrence, and to improve patients' quality of life. Depends on the severity of symptoms and extent of the disease, we have medical treatment, surgical treatment, or combination of both. In medical treatment, if there is an underlying allergy, you have to control the allergy. We usually give the antihistamines. We have to be careful when prescribing analgesics because there is the aspirin intolerance is common. Corticosteroids. It is the most effective medical treatment. We have local corticosteroids and systemic corticosteroids. Fluticasone, mometasone, piclomethazones are commonly used intranasal corticosteroids, and we usually recommend twice daily for several weeks for optimal effects to be appreciated. Oral corticosteroids is indicated in severe cases as the initial therapy, and we usually give short course and high dose for 10 days to 3 weeks. And we have to continue with the local corticosteroids after systemic steroid therapy. These are some contraindications because of side effects: hypertension, peptic ulcer, diabetes, pregnancy, and tuberculosis. But side effects are less common in local corticosteroid therapy, and local corticosteroid therapy is generally safe. Sometimes or occasionally you will see epistaxis or nasal mucosa ulceration. Oral steroids are more effective, but higher incidence of systemic side effects like hypertension, stomach upset, weight gain, and so on. What are the roles of antibiotics? Roles of antibiotics is to treat the infection, especially in acute exacerbations in these cases. Usually, we give amoxicillin, clavulanic acid, cephalosporins, macrolides, and doxycyclines, usually short courses. Long-term antibiotics is considered when nasal steroid sprays fail to control symptoms. Usually, 3 months course of macrolides are given, usually clarithromycin and azithromycin. So these drugs have the antimicrobial action. Apart from that, they influence the inflammatory response like increased mucociliary response, reduce goblet cell secretion, accelerate apoptosis of neutrophils. Then they reduce the symptoms of chronic inflammation, but it has its own side effects. With this medical treatment, sometimes polyp disappears. We call it medical polypectomy, but usually the size of the polyps is reduced. So if failure to respond to this maximum medical treatment, surgery is indicated. Sometimes if very severe symptoms, surgery is indicated, and another indication is if there is associated complications, surgery is done. Informed consent is very important because we have to explain surgery cannot cure the disease because nasal polyp is a consequence of underlying mucosal inflammation, but it will improve the quality of life significantly. Recurrence is very common after surgery. That's why regular follow-up to continue medical treatment with steroid therapy is very important. These are the some methods of surgery in ethmoidal polyps: simple polypectomy, intranasal ethmoidectomy, extranasal ethmoidectomy, transethmoidectomy, enteral adenoidectomy. But nowadays, we use scopes, and functional endoscopic sinus surgery is the gold standard. And in functional endoscopic sinus surgery, we can avoid incision and avoid scars. In endocrine polyp, we can do coward-like operation, but functional endoscopic sinus surgery is again the gold standard. This is the picture of coward-like operation, and this is a specimen. In functional endoscopic sinus surgery, we use various endoscopes, 0 degree, 30 degree, 70 degree, to check every angles in the nasopharynx, nasal cavity, and paranasal sinuses. It is minimally invasive technique and generally safe and well tolerated. The aim of the surgery is to restore the sinus ventilation, because if proper drainage and ventilation is provided to the sinuses, most of the changes are reversible and we can restore the normal physiological function. That's why this surgery is named functional endoscopic sinus surgery. By using the scope, surgery is more accurate and we can remove only the diseased mucosa and polyp, and we can preserve the normal mucosa. In addition, we open and widen the sinus air cells under direct visualization to provide drainage and ventilation and produce larger sinus cavity, more accessible to topical corticosteroids and saline application in post-op period. Post-operative care is very important because surgery is not cure the disease, so we have to continue local corticosteroids to reduce the recurrence and to create the long-term efficacy of surgery. We have development in treatment because we have better understanding of etiology and pathogenesis, but these are in clinical trials, and in some countries, they use as adjuvant therapy. So prevention. How to prevent these nasal polyps? The aim is to reduce the risk of developing polyps or to reduce the chance of recurrence after surgery. So to avoid irritants that can cause inflammation in the nose and sinuses, like cigarette smoking, dust, pollen, allergens, or treat the underlying conditions that can contribute to nasal polyps, like allergies, asthma, infection. So take-home message, so nasal polyp is not a non-neoplastic condition. It is not a benign tumor. It is not a malignant tumor. It is just a mucosal edema, but it causes a variety of symptoms, including blocked nose, reduced sense of smell, difficulty in breathing through the nose, snoring, and persistent post-nasal drip. It may be single or multiple, unilateral or bilateral, depends on the type and origin of the polyps. And we have medical treatment and surgical treatment, including steroid nasal spray and functional endoscopic sinus surgery. And don't forget how to prevent these nasal polyps by avoiding the irritants, allergens, and treating the underlying conditions. These are my references, and thank you very much for your kind attention. Thank you.
Thank you, Prof. Thank you for the wonderful talk. I would like to ask the participants if they have any question to ask Prof. Nilar. Please post your question in the comment box if you have any question. Prof, looks like no any further questions. So with this, I would like to thank once again Prof. Nilar.
Thank you very much.
Thank you so much. And I would like to introduce the second speaker of the day, Associate Professor Uday Singh Dadhwal. And today, regarding the Prof. Uday Kumar, he graduated from Guwahati Medical College, Assam, and then post-graduation in general surgery from Armed Forces Medical College. Pune University. Then he served for Indian Army for 22 years. Is very interested in laparoscopic surgery, gallbladder surgery, groin hernia repair, and thyroid surgery. He is also a member of Association of Surgeons of India, ASI, and member of Royal College of Surgeons, Ireland. Is having experience of teaching both the undergraduate and postgraduates in general surgery more than 10 years. And without further ado, I would like to invite Prof. Uday Kumar to talk on guidelines for the detection and management of bile duct injury during cholecystectomy. So the floor is yours, Prof.
Thank you, Prof. Suresh, for the kind introduction.
Thank you,
Good
Prof.
afternoon to everybody. So today I am going to speak on the topic guidelines for the detection and management of bile duct injury during cholecystectomy. So this is based on the 2020 World Society of Emergency Surgery guidelines. I have chosen this topic because laparoscopic surgery, cholecystectomy, is one of the commonest operations performed by general surgeons, and bile duct injury is the most feared complication. So let us find out more. We know that laparoscopic cholecystectomy is the gold standard operation for patients with gallstone disease. It is one of the most common routine interventions performed worldwide in both elective and emergency settings. Since early reports, the frequency of bile duct injuries during laparoscopic cholecystectomy has been progressively decreasing. The injuries seen currently tend to be more severe and include biliary, hepatic artery, and portal vein injuries. They often occur after conversion from laparoscopy to open surgery. Bile duct injury is a dangerous complication of cholecystectomy, and mortality can be as high as 3.5%. Bile duct injuries, they have an estimated incidence of 0.4 to 1.5% when it is done laparoscopically, and 0.2 to 0.3% when it is done as an open procedure. And it is associated with significant post-operative morbidity that has got long-term consequences as it affects the quality of life. Now, the injuries are either recognized during surgery in the form of bile leak, when a yellow golden bile is seen during the surgery, or in the immediate post-operative period in the form of bile leak that collects or drains out, or in the form of bile duct obstruction. Some bile duct injuries may be discovered during the late post-operative period in the form of bile obstruction, when it leads to bile duct strictures and presents with obstructive jaundice. Therefore, providing a specific diagnosis and a precise description of the bile duct injury is essential to help in the decision-making process and increase the chance of treatment success. The choice and timing of the appropriate reconstructive strategy, they have a critical role in the long-term prognosis of these patients. So just to revise the anatomy of this region, we can see that the gallbladder joins the common hepatic duct to form the common bile duct. And the gallbladder is supplied by the cystic artery, and this is the branch arising from the right hepatic artery, and this one is the hepatic artery proper. So if we magnify this view, we can see that there are so many blood vessels, and they become even more prominent when there is acute inflammation in this region. So in this picture, you can see that this is the gallbladder, the cystic duct, this is the bile duct, this is the Rovius fissure, this is the left hepatic artery, and this is the duodenum. So all these structures are this is the normal view of the anatomy. But when there is an acute inflammation, the gallbladder appears to be edematous. There are adhesions, it is swollen and distended, and it is very difficult to grasp and lift or retract, making the surgery difficult. Another point of interest during this surgery is the hepatocystic triangle. So this triangle is bounded by the lower border of the liver, the distal gallbladder, and the cystic duct, and the common hepatic duct. So this is the area of interest through which the cystic artery passes and is to be dissected. So in 2019, the World Society of Emergency Surgery decided to formulate guidelines so as to improve the outcome in patients who undergo the laparoscopic cholecystectomy. So they wanted to define the strategies so as to minimize the risk of bile duct injury during cholecystectomy. They also wanted to define the bile duct injury rates in general surgery units and review of surgical practice, how to classify, stage, and report a bile duct injury once it is detected. And they also wanted to define how to manage intraoperatively detected bile duct injury and how to manage a post-operatively detected bile duct injury. What are the indications of antibiotic treatment in these patients, and what are the indications for clinical, biochemical, and imaging investigations for suspected bile duct injury. So basically, they had these 7 questions or problems in mind that needed to be solved. So, to solve these 7 issues, a literature evaluation was conducted by performing bibliographic searches related to the 7 key questions uh, in the PubMed and Embase. There was no date or language restriction in the database search. Within each group, based on the literature evidence, clinical experience, and expert discussion, the experts were instructed to formulate statements and recommendations. The quality of evidence was graded as high, moderate, low, or very low, and the strength of the recommendation was indicated as either strong or weak. So, one by one, I'll speak out the 7 key questions. So, question 1: what are the general recommendations to minimize the risk of bile duct injury during laparoscopic cholecystectomy in elective and emergency settings? Question 2: what are the reported bile duct injury rates during the laparoscopic cholecystectomy in emergency and elective settings? And when should a surgical team review its current practice to improve the standards of care? Which classification of bile duct injury should be adopted? And what is the minimum required information that the surgeon must report after diagnosing the bile duct injury during a laparoscopic cholecystectomy? What are the surgical management strategies and timing for intraoperatively diagnosed bile duct injury? What is the recommended type and duration of antibiotic regimen in cases of bile duct injury? Question 6: what are the clinical, biochemical, and imaging investigations which are required for the post-operative diagnosis of bile duct injury? And what are the surgical management strategies and timing of post-operatively diagnosed bile duct injury? So, once the guidelines are found, they come with a disclaimer that these guidelines must be considered as an adjunctive tool in the decision making process regarding the management of the bile duct injuries. They are not intended to substitute a provider's clinical judgment regarding an individual patient or specific clinical situation, and they may be adapted to be consistent with the medical team's experience and the available local resources. So, now, what are the recommendations? So, to the first question, which states that what are the general recommendations to minimize the risk of bile duct injury during laparoscopic cholecystectomy in elective and emergency settings? So, the first recommendation says that the use of the critical view of safety during laparoscopic cholecystectomy by achieving all 3 components is the recommended approach to minimize the risk of bile duct injuries. This is a strong recommendation, though the quality of evidence is low. So, what is this critical view of safety? The critical view of safety has got 3 components. The first is the fibrofatty tissue should be cleared from the hepatocystic triangle, which I showed earlier. This is the hepatocystic triangle. So, all the fibrofatty tissue has been removed clearly, and only 2 important structures are seen entering the gallbladder. The lower part of the cystic plate has been clearly exposed in this region by separating the gallbladder from the liver. And the third one, only two tubular structures are seen entering the gallbladder. One is the cystic artery and the other one is the cystic duct. So this critical view of safety was described by Strasberg in 1995, and the three critical steps that he described was the visualization of the hepatocystic triangle with no exposure of the common bile duct, which means that the dissection is kept as close to the gallbladder and cystic duct as possible. The second one is the exposure of the lower part of the gallbladder and its separation from the liver bed is important. And third, the visualization of only two structures that enter the gallbladder. One is the cystic duct and other one is the cystic artery. And achieving a complete critical view of safety is easily obtained in only about 50% of cases. The component which is most commonly incomplete or difficult to define is the clearance of the lower third of the gallbladder from the liver bed. And this usually occurs because of advanced inflammation or extensive fibrosis in this region. So the surgeon must report during which of the severe steps the difficulties were encountered and the bile duct injury occurred. If the critical view of safety is not achievable because of the reasons that I mentioned just now, during a difficult surgery, a bailout procedure or an alternative approach or a plan B should be considered. And some of these alternative approaches include a subtotal cholecystectomy. This has got a strong recommendation. So what are the alternative approaches that a surgeon can resort to? So one of them is the fundus first or top-down approach. So in this case, the surgery is started from the fundus, then the body, and we move towards the cystic artery and the cystic duct. This approach is associated with reduced conversion rate and iatrogenic complications, including bile duct injury during the difficult surgery. But the risk of vascular and biliary injuries cannot be completely eliminated even with this approach. The other alternative approaches or the bailout procedures include a subtotal cholecystectomy or a partial cholecystectomy, one, and the other one is cholecystostomy. So in subtotal cholecystectomy, as much of the gallbladder as can be dissected safely is removed, and in the remaining part, the mucosa is either fulgurated or it is excised, and the opening of the cystic duct inside the gallbladder is closed with a purse string suture. So, and the other option is the cholecystostomy. This is done in those situations in which even this much dissection is not possible. It is not possible to expose the whole of the gallbladder. So the contents of the gallbladder, that is infected bile and all the stones are removed. The irrigation is done with saline and the cavity of the gallbladder is drained by a tube. So these approaches, they minimize the need for conversion and also reduce the risk of bile duct injury. Though the subtotal cholecystectomy is associated with significantly more surgical site infections, the need for reinterventions, and a longer hospital stay than a total cholecystectomy. Also, the subtotal cholecystectomy shows advantages over a converted cholecystectomy, in which conversion will not solve the difficulty of an inflamed hepatocystic triangle. The third recommendation is that the conversion to open surgery may be considered during a difficult lap chole whenever the operating surgeon cannot manage the procedure laparoscopically, either because of less experience, or because of some other difficulties encountered. But however, there is insufficient evidence to support conversion to open surgery as a strategy to avoid or reduce the risk of bile duct injury in difficult surgery. The fourth recommendation states that the intraoperative cholangiography is a useful adjunct to recognize bile duct anatomy or choledocholithiasis, which is the presence of stones in the bile duct in cases of intraoperative suspicion of bile duct injury. So this is basically used to visualize the bile duct, or if there is any misunderstanding of biliary anatomy or inability to see the critical view of safety. So visualization of bile duct is done by the use of intraoperative cholangiography, in which contrast is injected and images are taken to see the bile duct anatomy. Now there is another method to see the bile duct anatomy. It is called indocyanine green cholangiography. This is a non-invasive tool to recognize the bile duct anatomy and the vascular structures, but its routine use to reduce the bile duct injury is still not recommended. So this will highlight the bile duct injury, and other structures like fibrous bands can be excluded by this technique. That may cause confusion during a surgery. The sixth recommendation is that in patients presenting with acute cholecystitis, the optimal timing of cholecystectomy is usually within 48 to 72 hours, as is the standard teaching. But they have recommended that no more than 10 days from the symptom appearance should take before this, beyond which the surgery should be done. So up to 10 days is the recommended safe period for performing laparoscopic cholecystectomy. After this period, the chances of bile duct injury becomes very high. The seventh recommendation is that in patients with at-risk conditions or high-risk conditions like scleroatrophic cholecystitis, in which there is fibrosis or fibrotic atrophy of the gallbladder, or in Mirizi syndrome, in which there is a stone stuck in the cystic duct which causes partial or complete obstruction of the common hepatic duct. These are difficult situations. So in such situations, an exhaustive pre-operative workup prior to cholecystectomy is mandatory in order to discuss and balance the risk versus the benefit ratio for this procedure. Now we come down to the second question. Second question is, what are the reported bile duct injury rates during laparoscopic cholecystectomy in emergency and elective settings? Which is what are the standard, what are the international rates of injury, and when should a surgical team review its current practice to improve the standards of care? So based on large nationwide databases and systematic review of literature, major bile duct injuries are seen in 0.1% of elective lap chole and 0.3% of emergency lap chole. If we consider all types of bile duct injuries, the rates of 0.4% are seen in elective and 0.8% are seen in the emergency settings. So when a surgical team experiences an increased rate of bile duct injuries over and above these international rates, so in these cases, a careful review of the current practice is mandatory to critically analyze the possible causes and implement educational, training, and technical solutions so as to improve the standard of care and to improve the outcome of surgery. The third question, which classification of bile duct injury should be adopted, and what is the minimum required information that the surgeon must report after diagnosing bile duct injury during laparoscopic cholecystectomy? So now there are plenty of classifications of bile duct injury, and various authors report various classifications that lead to some kind of confusion. So the guidelines recommend knowing Strasberg's classification, which remains the most commonly used classification for bile duct injuries, and the ATOM classification, which represents the most recent and complete classification. The implementation of ATOM classification should be promoted in the near future. The second recommendation is that the ideal operative report must maximize the amount of intraoperative detail given to describe the bile duct injury, and the following points should minimally be included in the bile duct injury report. Number one is the clinical context and the indication for cholecystectomy, intraoperative findings, the anatomical landmarks of the critical view of safety, any anatomical variations or anomalies of the biliary tract, cholangiography findings if it was performed, all the operative data, including operative time, blood loss, use of energy device, and any need for conversion. A drawing or sketch of the bile duct injury with biliary drain placement should also be provided. A video recording of the procedure whenever available should also be attached. Now this chart shows all a variety of or various types, various classification systems used for bile duct injuries. So in this, you can see this Strasbourg classification system, which describes minor bile duct injuries and major bile duct injuries. And we have atom classification system. So various systems have used various aspects of injuries that leads to confusion. So now we have this latest atom classification of bile duct injury that has been provided by the European Association for Endoscopic Surgery. And this includes the atom stands for anatomical characteristic, time of detection, and mechanism of injury. The anatomical characteristics basically include whether it is an occlusion of the biliary tract or a division of the biliary tract. C stands for complete, P stands for partial, and LS stands for loss of tissue or loss of substance. In the middle, we see vasculobiliary injury. If there is any associated vascular injury of the nearby vessels like the right hepatic artery, common hepatic artery, they should be reported. The time of detection, either it is early intraoperative, early post-operative, or late. It has to be reported. And the mechanism of injury, it could be either mechanical injury or use of energy devices. So that also should be reported. Now we come to the fourth question. What are the surgical management strategies and timing for intraoperatively diagnosed bile duct injury? So for bile duct injury that is detected during surgery, the guidelines recommend the selective use of adjuncts for visualization of the biliary tract. These modalities that help in visualization include intraoperative cholangiography or indocyanine green cholangiography or the use of intraoperative ultrasound during a difficult laparoscopic surgery or whenever a bile duct injury is suspected, so as to increase the rate of intraoperative diagnosis of exact site and extent of surgery. In difficult cases, the opinion of another surgeon should also be taken into consideration. The second recommendation is that a direct repair with or without a T-tube placement may be considered in case of minor bile duct injuries, whereas for major bile duct injuries, a hepaticogynostomy should be considered as the treatment of choice. Now, in this diagram, I have shown this is for minor bile duct injuries where the injury is repaired over a T-tube to allow a drainage both distally as well as outside so as to allow the healing of the repair. Whereas in major bile duct injuries that is associated with devascularization of the duct is transected and is anastomosed to a taken up loop of jejunum. So this is called as Roux-en-Y hepaticojejunostomy. The third recommendation says that for injuries up to 72 hours is called as early bile duct repair. It may be considered in cases of appropriate surgical indication and availability of expertise. But if the expertise is not available, if the surgeon who has got hepatobiliary surgery experience is not available, in that case, a referral to an advanced center should be done within 72 hours. The fourth recommendation is that a systematic, immediate repair of isolated injuries of the left hepatic artery is not recommended. So if there is also associated vascular injury, it is not recommended and the benefit or risk ratio should be evaluated carefully. So it has been found that the injury to the right hepatic artery is usually well tolerated by the patients, and difficulties, if they occur symptomatic, they are seen in less than 10% of the patients and they can be managed at a subsequent time once the patient is stabilized. The repair of complex injuries like vasculobiliary injuries in which there is both biliary as well as vascular injury, they should be delayed and not attempted intraoperatively even by the expert hepatopancreatobiliary surgeons because it requires extensive workup to visualize, to image these vascular injuries and to define the extent of the injury. So stabilization of the patient becomes more important at this stage. So to summarize, the intraoperative detection of bile duct injury during laparoscopic cholecystectomy, 2 points are very important. One is the local resources availability, and number two is hepatopancreatobiliary surgery experience. So if it is not available, the surgeon should place a drain and refer the patient to the advanced center. If these facilities are available and if there is no associated vascular injury, if local resources are available, if hepatobiliary experience surgeon is available, but if there is no associated vascular injury, in that case, bile duct injury staging should be done. If it is a minor bile duct injury, a direct repair with or without a T2 placement should be done. If it is a major bile duct injury, then Roux-en-Y hepatocystectomy is done. If there is associated vascular injury, then that staging may be done. If it is a right hepatic artery injury, then immediate repair may not be attempted and observation may be done. In advanced centers only, direct repair may be attempted. If there is associated portal vein with or without right hepatic artery repair, then carefully consider repair or perform hepatectomy. If there is liver injury as also associated, then hepatectomy is done. If there is no liver injury associated, in that case, either workup and delayed repair should be done once the condition of the patient is stabilized. Coming to the fifth question, what is the recommended type and duration of antibiotic regimen in these patients with bile duct injury? So in cases of suspected bile duct injury during elective laparoscopic cholecystectomy without a history of any previous biliary drainage or any biliary surgery or procedure, the antibiotic therapy may be considered using broad spectrum antibiotics depending upon the condition of the patient. But in patients with previous biliary infection like cholecystitis, cholangitis, and patients with preoperative endoscopic stenting or endoscopic biliary drainage or any biliary procedure that has been done, these patients have a risk of developing local and systemic sepsis. So in these patients, broad spectrum antibiotics like fourth generation cephalosporins are recommended and further adjustments are done according to the progress of the patient. The third recommendation is that in patients with biliary fistula, biloma, which is a collection of bile inside the peritoneal cavity, or bile peritonitis, the antibiotics should be started preferably within 1 hour. And these are various antibiotic options. In some cases, fluconazole antifungal may also need to be added. The fourth recommendation is that in severe complicated intra-abdominal sepsis, where the condition of the patient is very bad, if there is severe intra-abdominal peritoneal infection, open abdomen can be considered, in which the abdomen is kept open and it is covered with a Bogota bag and is considered as an option for patients with organ failure and gross contamination. This helps in allowing the drainage of any peritoneal cavity infections. Coming to the sixth question, what are the clinical, biochemical, and imaging investigations required for the post-operative diagnosis of bile duct injuries? So if the bile duct injury is diagnosed post-operatively, so the guidelines recommend a prompt investigation of patients who do not rapidly recover after laparoscopic cholecystectomy. And so any patient who has undergone lap chole and who develops symptoms like fever, persistent abdominal pain, distension of the abdomen, jaundice, nausea, and vomiting. So these patients will require further investigations as their recovery is not the usual recovery. So in these patients, the assessment of liver function tests, including serum levels of direct and indirect bilirubin, AST, ALT, ALP, gamma GT, albumin is suggested. In these patients with clinical signs and symptoms of suggestive of bile duct injury after laparoscopic cholecystectomy. In patients who are critically ill, the serum levels of C-reactive protein, procalcitonin, and lactate may help in the evaluation of the severity of acute inflammation and sepsis and in monitoring the response to the treatment. The third recommendation regarding imaging. So there are various modalities of imaging that can be used in patients with bile duct injuries, including ultrasound, CT, MRI, then hepatobiliary scintigraphy, the ERCP, percutaneous transhepatic cholangiography, the various modalities, but the guidelines recommend that the abdominal triphasic CT is suggested as the first line diagnostic imaging investigation to detect any intra-abdominal fluid collections that can include serum, blood, bile, and also ductal dilatation. It may be complemented with the addition of contrast enhanced MRCP to obtain the exact visualization, localization, and classification of the bile duct injury, which is essential for planning a tailored treatment for these patients. The last question: what are the surgical management strategies and timing of for post-operatively diagnosed bile duct injury? See, so in the case of a minor bile duct injury, that is Strasbourg A to D, if a drain is placed after surgery and a bile leak is noted, an observation period and non-operative management should be done for the first few hours. If no drain has been placed after lap chole, which is done by majority of the surgeons during surgery, a percutaneous treatment of the collection with drain placement can be done under ultrasound guidance. The second recommendation is that for minor bile duct injuries, if no improvement occurs after the placement of the drain or there is worsening of the symptoms that occurs during the clinical observation period after percutaneous drain placement, an endoscopic management by ERCP, that is endoscopic retrograde cholangiopancreato, with biliary sphincterotomy and stent placement is done. This allows preferential drainage of bile into the duodenum. For major bile duct injuries that are diagnosed in the immediate post-operative period, that is within 72 hours after the surgery, the guidelines recommend referral to a center with expertise in the hepatobiliary procedures if that expertise is locally unavailable. An urgent surgical repair with biliary-enteric anastomosis by Roux-en-Y hepatogenostomy could be performed if the expertise is available. The fourth recommendation says that in major bile duct injuries which are diagnosed after 72 hours and within 3 weeks, the guidelines recommend percutaneous drainage of the fluid collections whenever present, targeted use of antibiotics and nutritional support. So what happens during this period? An ERCP with sphincterotomy with or without a stent can be considered to reduce the pressure gradient in the biliary tree, and this allows the drainage of bile. And a PTBD, that is percutaneous transhepatic biliary drainage, could also be useful for septic patients with a complete obstruction of the common bile duct. So after a minimum of about 3 weeks, if the patient's general condition improves and acute or subacute situation or inflammation resolves in the form of closure of the biliary fistula, a Roux-en-Y hepatogenostomy should be performed. The fifth recommendation for this question number 7 is that when major bile duct injuries are recognized late after the initial laparoscopic cholecystectomy and there are clinical manifestations of a stricture in the form of obstructive jaundice, then a Roux-en-Y hepatogenostomy should be performed. When major bile duct injury is present as diffuse biliary peritonitis, in that case the peritoneal cavity should be irrigated with saline, a lavage should be done, and drains are placed in the subhepatic region and in the pelvis as the first step of treatment in these patients. So this is the summary of the post-operatively detected bile duct injury after laparoscopic cholecystectomy. So once it is detected, a bile duct injury staging should be done. If it is a minor bile duct injury, if there is bile duct injury from the drain, which means if a drain has been placed, then non-operative management should be done initially. If the patient improves, then it's good. If the patient does not improve, if there is worsening, then ERCP with sphincterotomy and stent placement should be done. If there is bile collection on imaging, in which if no drain was placed, in that case, local resources are available, experience is there, then percutaneous drain placement should be done under image guidance. If there is peritonitis, then laparoscopic lavage and drainage should be done. If patient develops jaundice, that means there is an obstruction, then ERCP should be done. Now, if these facilities are not available, local resources not available, hepatobiliary surgeon is not available, in that case, referral to the higher center should be done. In case of major bile duct injury, if it is diagnosed within 72 hours or between 72 hours to 3 weeks or after 3 weeks. So within 72 hours, a Roux-en-Y hepatogenostomy should be performed between these between 3 days to 3 weeks. If resources are available, then depending upon the clinical manifestation, the clinical condition of the patient, whether the patient has got a fistula or has got jaundice or stricture or has got peritonitis, the percutaneous drain placement or ERCP or PTBD should be performed with supportive therapy with antibiotic and nutrition management. If it is diagnosed after 3 weeks, in that case, a Roux-en-Y hepatocholectomy should be performed. So what are the outcomes of bile duct injury treatment? Bile duct injury diagnosis can be made early or late during the post-operative period. It is important to emphasize that the evaluation of bile duct injury management and repair outcomes should be pursued in the long term, since late complications like post-cholecystectomy biliary strictures, recurrent cholangitis, and secondary biliary cirrhosis may occur. Many of these patients go on to develop portal hypertension, liver failure, and other complications, so they require a lifelong follow-up. These these cases also have medico-legal aspects. In Europe, approximately 19 to 32% of patients with bile duct injuries are involved in a litigation claim, which translates into medical liability of the operating surgeon and with significant payouts. So these data highlight the importance of preoperative informed consent, in which the possibility of severe complications like bile duct injuries should be adequately explained to the patient. A straightforward and honest communication once the bile duct injury has occurred and detected is also crucial in such cases. So to conclude, I will say that laparoscopic cholecystectomy is one of the most common operations a general surgeon performs in elective and emergency settings worldwide. Bile duct injury during laparoscopic cholecystectomy is a severe complication that requires prompt diagnosis and specific treatment to avoid further morbidity and mortality. The practice guidelines have been proposed to prevent bile duct injuries during laparoscopic cholecystectomy. So, therefore, it is critical to have a plan if an injury is detected intraoperatively and to follow a standardized protocol in case of a delayed diagnosis during the postoperative period. This is my reference. Thank you very much.
Thank you so much, Prof. Now I would like to ask participants to leave any questions to Prof. Uday in the comment section. So there are some comments for appreciating you, Prof.
Thank you.
Thank you so much, Prof, for giving a wonderful insights on the identification and management of the bile duct injury. So if there is no any further questions, we would like to stop today's CME event. Thank you so much once again.
Thank you very much. Thank you.
Okay. One more comment, Prof, from Prof. Veena Joshi. Interesting talk, Prof.
Thank you. Thank you.
Okay, thank you once again, all of you, for participating, and have a nice weekend. See you. Bye.